I'm Anna Hoffmann-Vold, a rheumatologist from the Oslo and Zurich University Hospital. Today I will talk about the management of interstitial lung disease in rheumatic diseases, which we will refer to as connective tissue disease, which also includes RA. And I will present you some of the data from our guideline, which was very recently published in the Annals of Rheumatic Diseases and the European Respiratory Journal. And our task force was based on the two societies, as I said, from the European Respiratory Society and EULAR. And we included a large panel of both pulmonologists, rheumatologists. We also had a radiologist, a pathologist involved, and patient research partners. We also used methodologists both from EULAR and ERS, but as it was an ERS initiative, we followed the ERS grade methodology. And our entire guideline is based on strong and conditional recommendations, either for or against. And we phrase in our guideline our answers as we recommend when it's a strong recommendation, or we suggest if it's a conditional recommendation. I will try to keep on this wording also while I'm talking to you about the results. And but just if you also read the paper, remember these are already pointing you into the direction whether we have a strong or conditional recommendation. And we were initially asking ourselves about how should we screen patients, how should we diagnose them, monitor, and treatment. And we divided these four main categories into 5 PICO questions and 10 narrative questions who are supportive for our PICO questions. And then we answered them per disease. And we looked at our diseases as groups into systemic sclerosis, rheumatoid arthritis, idiopathic inflammatory myopathies, or other connective tissue diseases, which included Sjögren disease, mixed connective tissue disease, and SLE. At the end, because of this, we ended up with 25 PICO questions and 28 narrative questions, and we could make 18 conditional recommendations, 6 strong recommendations for the PICO questions, 1 we couldn't answer, and we had at the end for the narrative questions 23 conditional recommendations, no recommendations, and 3 strong recommendations. And to really understand our guideline, it is also important to understand the questions we were asking each other, because this is a little bit the basis for the answers. And I will talk about today, just briefly show you the questions and then go straight to the algorithms which we built, which are very practical for clinical practice to use for you. But if you want to see all the details, please look at our publications and you will also find an overview of every single recommendation and suggestions. So for the screening, we were asking ourselves, can we replace lung function tests or can we use lung function tests instead of HRCT for the screening? And can we use lung ultrasound instead of HRCT for the screening of ILD? Then we were also asking ourselves which patients should be screened and how often should patients be rescreened, so if the initial HRCT was negative. That was one of the questions we couldn't answer, so there was no recommendation made. For the other recommendations, we built this very nice screening algorithm. And here you can see that it's really based on the underlying rheumatic disease. So for systemic sclerosis, so for all diseases, we said that lung function tests cannot replace HRCT. So HRCT is the screening approach for our patients. Also, lung ultrasound is at that time point not able to replace HRCT. And then to see at which patient we should screen, for systemic sclerosis and mixed connective tissue disease, we strongly recommend that you screen all patients. For myositis, we say that if a patient has risk factors, then also a strong recommendation to screen this patient using HRCT. If you have a myositis patient who does not have risk factors for ILD, we have a conditional recommendation for screening these patients. So what it means for myositis is also that you should screen all of your myositis patients at time point of diagnosis with an HRCT, except for inclusion body myositis. When it comes to RA and Sjögren, it's really about to identify the at-risk patient. And the at-risk patient is defined as having 2 or more risk factors for the development of ILD. And these patients should also be screened with an HRCT. While RA patients and Sjögren patients with no risk factors do not need to be screened. All of these risk factors are also identified by the literature review and available in the document. And of course, at the time point, once you do screen, you do identify pathologies, also always consider doing a lung function test in these patients. When we talk about diagnosis, here we looked at no PICO questions, but for the narrative questions, we were asking how should we evaluate patients at baseline once we diagnose ILD, then what is the role of BAL, and what is the role of lung biopsy in diagnosing ILD in rheumatic diseases. So, and I can already say that lung biopsy does not play a role in the diagnosis of ILD in rheumatic diseases. BAL is only considered as important if you have any suspicion for coexisting conditions. So it also doesn't play a role in the diagnosis, but we still conditionally recommend it if you have a doubt whether there's an infection or any other underlying cause. Then, very importantly, what we do recommend for the diagnosis is once you diagnose a patient with ILD on HRCT, you should at that time point already assess the prognosis, risk of progression, and risk of development of severe disease. And here we identified several categories how you should do this. So we said you should use clinical risk factors. And again, we do have identified risk factors for RA, systemic sclerosis, and myositis who are at clinical higher risk of ILD, worse ILD or ILD progression. So these you should use. You should look at the lung function test. How impaired is FVC? How impaired is DLCO? In some patients also FEV1 for airway disease. Then you should look at the HRCT pattern and extent. You should conduct a 6-minute walking test and look, does the patient desaturate? And you should use patient-reported outcome measures, especially to map respiratory symptoms. And all of these tools will give you an idea how this patient is at risk of progression and more severe disease. And this already should make up your mind, and you should write it down in the charts. Is this a patient at higher risk or not? And I will come back to this when we talk about monitoring, because this is exactly the same approach. You should also do it every visit over time to monitor. So then let's talk about monitoring. So first, our questions again were no PICO questions, but we were asking ourselves, what is the role of the 6-minute walking test? What is the role of PROs, so patient-reported outcome measures? And in which patients there should be a follow-up with PFTs and how often? So how often should they come back for lung function tests? And we ask ourselves, when should we repeat an HRCT? And all these questions, again, led up to building these algorithms for every patient group. So here you have first this systemic sclerosis ILD monitoring approach. And to monitor systemic sclerosis interstitial lung disease patients, you should, exactly as I just told you for the diagnosis, make up your mind. Is this a patient at higher risk of severe disease and progressive disease, or is this a patient at lower risk? Once you have made up your mind, you should, in the next step, take into account, is this a patient with shorter disease duration or longer disease duration? And what this gives you, this risk score of risk profile and disease duration, is to identify the patients who need a closer monitoring and a less closer monitoring. So a high-risk patient with a short disease duration has a closer follow-up than a patient at low risk with longer disease duration. But every patient should get a lung function test, considered for the follow-up: an HRCT, again with a pattern and extend, the 6-minute walking test with desaturation, and the measurement of patient-reported outcome measures. So when we look at patients with systemic sclerosis ILD at high risk with short disease duration, that patient should come back after 3 to 6 months for a lung function test, and at 12 months for an HRCT. And at 6 to 12 months, the patient should conduct a 6-minute walking test and a patient-reported outcome measure. However, for these two, compared to the PFTs and HRCT, we did not identify any literature. So this is really based on expert opinion and suggestions from the experts, not based on the evidence we identified. And this is also how you should read the entire algorithms. If we provide you with colored boxes stating something like the frequency of monitoring, then this is based on data. If we, in the algorithm, give you white boxes with a blue frame, this is a suggestion from the task force when to repeat the different tools in the monitoring of our patients. And actually, the risk assessment should be done at every visit the patient comes back, because risk factors can change. A patient can be more at risk even after a longer disease duration, or have less risk factors and get into the category of being less prone of developing a more severe disease. The risk factors we identified, the clinical risk factors in systemic sclerosis ILD for a more severe disease, which you should look out for in clinical practice, were male gender, older age, inflammation, so with increased CRP, ESR, the presence of anti-topoisomerase 1 antibodies, lung function test, and the extent of ILD on HRCT, and especially the combination of recent onset of systemic sclerosis with rapid skin progression and more extensive skin fibrosis. The other algorithms for RA, myositis, and other CTD-ILDs are exactly the same as for systemic sclerosis ILD. Always make up your mind whether this is at a higher risk of progression and severe disease patient. Look at the disease duration, and then look at, is this a high-risk patient, a low-risk patient with short and long disease duration, and tailor your management approach individually. And again, we suggest lung function test, HRCT, 6-minute walking test with desaturation, and patient-reported outcome measures. And based on the algorithms, you can really look at how often you should monitor your patient. For myositis, you should especially look out for patients who are male, older age. No, for rheumatoid arthritis, you should really look out for patients who are male, older age, who have anti-CCP and RF factors, who have low baseline lung function, who have the UIP pattern on HRCT or histological patterns of UIP, and in patients who have a higher articular disease activity. So these patients should be then monitored more tightly. For myositis, again, the same approach of monitoring, and I hope you have understood this from my first explanations. The patients you should be very careful about are patients with myositis with increased ferritin, so again, kind of an inflammatory marker, the presence of anti-MDA5 or anti-synthetase antibodies, and a higher extent of ILD on HRCT. So these are factors you should look out for your patient and put into the higher risk of progression category. Then we also identified some poor risk factors for especially MDA5 positive myositis patients. These were extent of ILD on HRCT, higher ferritin levels, KL6, older age, and low saturation. For the other diseases, including Sjögren and CTD, we had much less evidence, but we built up the same algorithm. So use, please, the same algorithm. Unfortunately, we did not identify any risk factors for poor outcome. So then the last question of our guideline was how we should treat. And here it is very important, again, to understand that we had 3 major questions. We were asking, should immunosuppressive treatment versus control be used? Should antifibrotic therapy be used? Or should a combination therapy be used? And then we wanted to identify key factors to identify the right treatment for the right patient. Again, I can tell you for this, we did not were not able to form a recommendation because we did not identify key factors for choosing drug A for patient A and so on. So this is why we considered using the inclusion criteria of trials as the best way currently to identify the right treatment. So this means if a patient fulfills the inclusion criteria of a certain trial, where a drug was tested, this drug is more likely to be working in this patient compared to a patient not fulfilling the inclusion criteria. This does not mean that the drug does not work in these patients, but it has not been tested. So this is how we then build up the entire algorithm. So for systemic sclerosis, we say that you should look out for patients, specific patient phenotypes to identify the right drug. So if you have a patient with interstitial lung disease who has either extrapulmonary involvement, such as the skin, drugs which are recommended in our guideline are mycophenolate or tocilizumab. And if you have an SSc-ILD patient with no extrapulmonary organ manifestations, still that would also be a patient which you could give mycophenolate, which is conditionally recommended. Then we have this very specific phenotype of early diffuse systemic sclerosis, signs of inflammation, who were the patients who were included in the trial testing tocilizumab. In this specific patient group, we strongly recommend to use tocilizumab. Then we have the patients with systemic sclerosis who have more than 10% ILD on HSCT, no extrapulmonary organ manifestations. And these patients, you should also consider nintedanib as a good choice for treatment. And then we have this group of high risk of progression patient where we recommend combination therapy. And in these, we conditionally recommend either the combination of nintedanib and mycophenolate or a combination of immunosuppressants. Other drugs we recommend, especially for this group, is cyclophosphamide or rituximab. And then we have the last group phenotype of patient with severe multi-organ involvement, where we really want to treat more than the lung, and we are very concerned about these patients. Here again, we suggest cyclophosphamide and rituximab, or the combination of immunosuppressants. So once you have chosen your phenotype, you have started the treatment, you of course need to monitor the patient. If the treatment goals are met, you can continue treatment. If these treatment goals are not met, we could not make a strong or a recommendation because there was no evidence to tell us what to do with the patient next. So the experts then again have a couple of suggestions, such as switching or adding on therapy based on, again, what we recommend in the first place. For RA-ILD, again, the treatment algorithm is very much based on identifying the phenotype. And for RA, it is really based on identifying patients who have active arthritis, because these patients need to be treated to target in their joints. And here, of course, immunosuppressive therapy comes up because these are the drugs which are also recommended in the EULAR recommendation for treating RA. What we did find is some very poor evidence for abatacept, rituximab, and JAK inhibitors. These were small studies, retrospective, only small numbers, single center, so not very strong, but we did identify. So this is why we also have them especially mentioned under the immunosuppressive therapy for patients with RA-ILD, where you want to treat the joints and the lung. And then, of course, we also have included tocilizumab and steroids, but this is based on expert recommendations rather than evidence. And then on the other side, we have the RA-ILD patients who have well-controlled arthritis, so we don't need to treat their joints. If you only want to additional treat with another immunosuppressive, we did not identify any evidence for mycophenolate and azathioprine, but we still include them. But if you have a patient then who has, in addition to well-controlled arthritis, severe and progressive ILD, here in these patients, you should consider a combination of immunosuppressants. If you have a patient with progressive pulmonary fibrosis, here there is evidence for nintedanib, either on its own or in combination with immunosuppressants. And then we also have patients with a UIP pattern, where we also, in addition to nintedanib, also suggest to choose pirfenidone if this is available for your country. Again, monitor your patient, treatment goals met, yes or no. If no, you need to, of course, change treatment strategies. For myositis, we have, again, two more or less groups. So one is the any myositis group. Here we strongly recommend immunosuppressive therapy. There's very little evidence, but we still, based on clinical experience, have a strong recommendation for using immunosuppressive therapy. The drugs we did identify for immunosuppressive drugs, we did identify poor low-level evidence, was steroids and CNI and rituximab. So these are good treatment choices for myositis. In addition, we also add mycophenolate and azathioprine, but we did not identify any evidence, but we also included this as expert recommendation for immunosuppressive therapy. If you have a high risk of progression or severe multi-organ involvement myositis patient, please consider upfront also combination therapy, which we conditionally recommend in these patients. And here we mention, of course, high-dose steroids, cyclophosphamide, rituximab, CNI, and IVIG. Once a patient has progressive pulmonary fibrosis, there again we have evidence for nintedanib, either in mono or in combination with immunosuppressants. And then we have this group of rapidly progressive ILD over weeks to few months that we did not identify any evidence, but we still recommend in these patients a combination therapy with high-dose steroids, cyclophosphamide or rituximab with CNI, IVIG, JAK inhibitors, plasmapheresis may be considered. All these are just suggestions from the experts, no clear recommendation based on evidence. The last group is other CTD-ILDs, which includes Sjögren and MCTD. Here we did not identify any direct evidence. So all the evidence which are formed to tell us the treatment is transferred from other diseases or studies including few of these patients. So here our mainstay is again that we conditionally recommend immunosuppressive. We did not identify any studies, as I said, so we could not identify specific drugs, but we do, as the expert panel, add mycophenolates, azathioprine, steroids, rituximab, and cyclophosphamide in that group. If you have a high risk of progressive other CTD-ILD patient with severe multi-organ involvement, again, also for these patients, we as experts suggest to use rituximab and cyclophosphamide, or we conditionally recommend a combination of immunosuppressants based from transferred evidence from other diseases. For PPF, again, here we do have evidence for nintedanib, either in monotherapy or with immunosuppressants. So that is really the only study where we could also give evidence based on the underlying studies. Again, monitor your patient. If progressive, if more severe, please add or switch therapy. So in conclusion, be aware of all of your rheumatic disease patients to screen them for ILD. The screening approaches differ based on the underlying disease. Screen all your myositis, scleroderma, and MCTD patients with HRCT, RA, Sjögren, identify risk factors, and screen the patients with risk factors with HRCT. A diagnosis, a thorough assessment of every CTD-ILD patient should be conducted with a clinical risk factor approach to identify the high-risk patients. Monitor your patients tailored individually based on the risk factors, including a large panel of different tools. And then for the treatment guidelines, there are guidelines now available or guidance available based on the underlying disease. We do include different immunosuppressive therapies. We do include nintedanib and for RA-ILD pirfenidone and a combination therapy in some of these patients. So I hope this was helpful, and I really hope that our guidelines will make your clinical management of patients with rheumatic disease and interstitial lung disease easier in the future. Thank you very much for listening.